Good afternoon. I'm Javier De Andres. I'm very happy to be here. I'm going to speak about lumbar medial branch radiofrequency neurotomy. I will go through the following topics. I will speak about the rationale for radiofrequency neurotomy because I think it's very important not only to know how to do things, but also why we do things. I will speak a little bit about basic lumbar anatomy and applied radiological anatomy. It's very, very important to know the anatomy on interventional pain treatment. Although this technique has been fantastically described under ultrasound, I think the safest way to perform this procedure is under fluoroscopy. Okay, so with all the disadvantages fluoroscopy has, I think it's the safest way of performing for our patients. I will then go, I will give some tips for selecting patients for radiofrequency neurotomy. It's very, very important to select the perfect patient for the perfect technique. Then I will go a little bit quickly through the radiofrequency neurotomy technique because I think these techniques should be taught in cadaver courses. They are what now is called bio-skills, and I think bio-skills are only learned from cadaver courses or face-to-face. So I don't think webinars, nor books, nor scientific papers, even though they are important, are not the proper way of learning the skills. And I will end up giving some tips for avoiding complications. So upon completion of this presentation, this webinar, attendees will be able to discuss the rationale for facet denervation, the anatomy of medial branch and how it innervates superficial joints, the importance of the mamellar accessory ligament, the importance of diagnostic or prognostic blocks. There is now a semantic war, or more than semantic, between diagnostic and prognostic. If medial branch blocks are diagnostic or prognostic, I'm not going to enter in that war, but I will insist in the importance of performing these diagnostic or prognostic blocks. Importance of proper selection of patients. I always tell my fellows, interventional techniques fail because patients are not properly selected, there are no good indications, and the technique is not properly performed. And as I said, I will give some tips for avoiding complications. Once again, I must thank Dina Patel and all Boston Scientific working group for promoting these fantastic cadaver courses we've had on the last 2 years in Düsseldorf, where there are we've got fantastic specimens. And the place is really fantastic for learning all these skills. So let's get started. Why do we perform radiofrequency neurotomy? The rationale for lumbar radiofrequency neurotomy. Well, there are many causes of low back pain. We know muscles pain. Muscles are richly innervated and are a source of low back pain. Quadratus lumborum, iliopsoas, multifidus muscles have been described as a source of low back pain. Intervertebral discs are also a source of low back pain. We know the innervation of the intervertebral disc, which is they are richly innervated in the outer, which is the annulus fibrosus, and the nucleus pulposus is not so richly innervated. And the innervation comes mainly from the autonomic system, the sympathetic system. Lumbar vertebra is also a source of low back pain. We know that collapsed or fractured vertebrae are very, very painful. And we know a little bit more about the anatomy of, for example, the basivertebral nerves, which are a new target for radiofrequency neurotomy, mainly in degenerative disc disease. We know muscle fascias are also a source of low back pain. For example, in failed back surgery syndrome patients, we know this thoracolumbar fascia is very, very painful. Ligaments are a controversial source of low back pain. Some say, for example, iliolumbar ligament is a source of low back pain, but recent studies, anatomical studies, say that it is not so richly innervated. But we can think of this source of pain, for example, in the cluneal area, which is a part of the low back, sometimes very, very, very difficult to treat. Facet joints are also obviously, and it's the main topic of this webinar, a source of low back pain. And there is also referred pain from other structures, from pelvic organs. We all know, for example, endometriosis can be an important source of low back pain, very difficult sometimes to treat. The term facet joints is a newly coined term. It was coined 20 years ago, and the real anatomical name is zygapophyseal joints. Zygapophyseal joints comes from the Greek, from the word zygos, which means yoke, connection, or bridge, and from physis, which in Greek means growth. So we can imagine these Roman bridges all over Europe and as part of our spinal anatomy. But why are lumbar zygapophyseal joints important? Well, they are important because, as we said before, they are a source of low back pain. Stimulating zygapophyseal joints evokes pain in the lumbar area, gluteal area, or thighs. So, zygapophyseal joints are also a source of referred pain in buttocks and thighs. So the take-home message would be zygapophyseal joints are a source of low back pain. But what is the rationale for radiofrequency neurotomy? Well, we know zygapophyseal joints are a source of low back pain, so anesthetizing zygapophyseal joints or anesthetizing the nerves that innervate the zygapophyseal joints can make lumbar pain disappear, at least temporarily.